Good evening. I am Sergio Aparicio. I'm the current Vice President of IFSO Latin American chapter. Tonight, on behalf of Dr. Luis Poggi, the current president of our chapter, I want to welcome you, everybody, to this second IFSO Latin American chapter webinar sponsored by IFSO Global. First of all, I want to thank to the Committee of Continuous Medical Education and Postgraduate Activities headed by Dr. Mariano Palermo, Edgardo Serra, and Camilo Boza. They have organized this interesting webinar. We'll take a look on an interesting and challenging issue tonight, that is metabolical the patient with obesity and an abdominal hernia. This is a problem that many metabolic surgeons must face, and it's important to have a refresh in this topic. We couldn't be happier with the first level speakers tonight, Dr. Enrique Arias from El Salvador and Andrés Hanssen from Colombia. Not to mention the first level group of panelists, Priscila from Argentina, Ernesto Escobar from El Salvador, Marcelo Loureiro from Brazil, Luis Zorrilla from Mexico. With no more preamble, I leave you with the moderators, Dr. Mariano Palermo. The microphone is yours. I hope you enjoy this and take advantage of this interesting webinar.
Thank you very much, Sergio. Thank you very much to all IFSO Latam and Global. The idea here is to have two talks. The first speaker will be Enrique Arias from El Salvador, as Sergio said, and we will have 15-20 minutes of talk, and then Andrés Hanssen is gonna give his lecture, and in the final minutes we will discuss with our panelists. So, Enrique, thank you very much for being here. You can share your screen, and the next 15 minutes are yours.
Okay. Hello to everybody. I would like to thank the organizer for this invitation. Today, I will talk about laparoscopic ventral hernia repair simultaneous to bariatric surgery, when it is recommended. Let me show you this slide. Okay. I have nothing to disclose, but I guess it's important to share with you my surgical experience. Okay. When this patient comes to our office with BMI of 56 and umbilical hernia asking for a bariatric procedure, it's not easy to make a decision. But it's harder when he is asking only for a hernia repair because he believes that obesity is not a real trouble for him. What should we do? Hernia surgery alone? Do the bariatric surgery first and operate the hernia at the second stage? Or do the bariatric surgery and hernia repair at the same time? We know obesity frequently related to ventral hernia. Obesity causes an overpressure of the abdominal cavity and also is associated to poor cicatrization. For this reason, it's not uncommon to see hernia in people with obesity and even more with morbid obesity. Intra-abdominal preperitoneal online mesh or IPON technique actually is not the best place for synthetic mesh, but is wide accepted for patients with hernia and obesity. On the most controversial question is to perform the bariatric surgery alone or repair the hernia or do the both procedure at the same time? Okay, 60% of patients consulting for a ventral hernia has any kind of obesity, and 8% of patients who have had Roux-en-Y gastric bypass had a ventral hernia. A very important point to decide two-stage operation or a single operation for patients with morbid obesity and hernia is to understand if we can or we cannot use a synthetic mesh in a clean contaminated filo. Traditionally, an elective ventral hernia repair is acceptable for patients under 30 BMI, prohibited from patients over 50 of BMI, and controversial between 30 and 50. If we decide to perform a simultaneous procedure in patients with ventral hernia and morbid obesity, the first three questions to respond are rate of recurrence, rate of infection, and the time in the operating room. On the other hand, if we decide to leave the hernia for a second stage, after significant weight loss, we can have several complications. Bowel obstruction due to an incarcerated hernia is one of the main concerns. My question to all of you guys is, what do you do if you find this kind of hernia in a patient during your sleeve gastrectomy or your gastric bypass? Okay, I will try to explain the reason, because we believe that it's feasible and safe to perform the hernia repair at the same time of bariatric surgery, in some cases, obviously. Okay. One of the reasons to make this decision is to answer if ventral hernia repair with simultaneous bariatric surgery has higher qual wound infection or mesh infection than a hernia repair alone. I will try to show you some data. Okay. First point, in general, laparoscopic ventral hernia repair has 3.1% of mesh infection, and around 0.7% of those patients need to remove the mesh. At this time, we are not talking about bariatric patients. We are talking about a study to compare open versus laparoscopic ventral hernia repair. Second point, the group of Cleveland Clinic, Florida, took culture to the patient who underwent bariatric surgery, and the result was all the sleeve gastrectomy was negative, and only 15 patients with gastric bypass result with positive bacterial cultures. Please let me show you this. This is a systematic review comparing biologic versus synthetic mesh in contaminated surgeries. The conclusion of this paper is the available evidence does not support the superiority of biologic over synthetic non-absorbent meshes in contaminated procedures. This is another study. The authors analyzed the American College of Surgeons database during the years of 2010 and 2011. Over 17 patients underwent bariatric surgery those years, and 503 had a simultaneous ventral hernia repair. Most of them were gastric bypass. The conclusion was simultaneous ventral hernia repair is not associated with higher infection rate and overall morbidity, and they didn't find significant difference between bypass and sleeve gastrectomy concerning surgery site infection. The Society of Emergency Surgery in their guidelines for repair complicated abdominal hernia established prosthetic repair with synthetic mesh can be performed without an increase in 30 days wound infection. Once again, if I have to answer you if simultaneous ventral hernia and bariatric procedure has higher infection rate, I can tell you the evidence show you there is no difference in terms of bone or mesh infection. Okay, the second question, do we have more recurrence doing both procedures at the same time? Let me show you some evidence. Okay. This is a 54 patient study with concomitant bariatric and ventral hernia repair. The average BMI was 44, all of them with ventral and umbilical hernia. Most of them have a sleeve gastrectomy as the bariatric procedure. They report one recurrence. The conclusion is ventral hernia repair simultaneous is feasible and safe with similar recurrence rate. Okay. This is a systematic review. 11 studies were included, almost 500 patients with simultaneous hernia and bariatric procedure. Means BMI was 46. They compared 3 techniques to close the hernia defects: suture alone, synthetic mesh, and biologic mesh. The majority of those patients underwent gastric bypass, and 93% of them has laparoscopic surgery. The defect size should be less than 4.8 diameter. Okay, the result in terms of recurrence was the patient with synthetic mesh has significantly less recurrence than patient with biologic mesh and primary suture, 1% versus 14 and 25% respectively. I want to show you this data because several times when I show some videos about hernia found during a bariatric surgery, most of you guys consider that the best option is just to put some stitches. If we do that, 25% of those patients will have a recurrence. And we know it could be a disaster if the small bowel incarcerated in the small hernia defects. Okay, the same study. Report 5 patients with a small bowel obstruction after closing the hernia defect with suture compared to no small bowel obstruction if they use synthetic mesh to close the defect. Okay. The conclusion is ventral hernia repair during bariatric surgery is feasible and safe for small hernia defect less than 5 centimeters. Synthetic mesh provide a significant lower rate of recurrence without an increase of mesh infection during sleeve gastrectomy and gastric bypass. I can show you more evidence, several papers with similar conclusion. Concomitant procedure of ventral hernia with bariatric surgery is feasible and safe. We don't have time to show all of them. Okay. I hope to convince you the evidence show us no increase of recurrence infection or infection rate if we do ventral hernia repair at the same times of bariatric surgery. Obviously, both procedures should be performed for surgery with experience doing them. Okay. I want to show you our experience. Okay. First, we use this technique to do both procedures at the same time. We start with reduction of hernia. After that, we perform the bariatric procedure. And finally, we do the hernia repair. Usually, we use composite mesh with a tacker for fixation. And sometimes we use transfascial suture, as you can see in the video. Okay, until 2020, we had 16 patients. Most of the patients are male, 31% with age above of 50. 5 of our patients had BMI above 50. That means super obesity, and we don't have a lot of paper about them. %19 of this suffer diabetes. The majority of those patients has hernia defect less than 5 centimeters, and almost most of them has any kind of gastric bypass or any kind of small bowel anastomosis. We use bariatric mesh of Medtronic as most frequently mesh. The mesh fixation graphic, as I told you before, we use tacker for all those patients and sometimes also transfascial suture. At least 1 year follow-up was required to be included in this study. The result was 1 patient has a port site infection. He just needs oral antibiotic. We don't have any mesh infection, and also we don't have any recurrence in this study group. Again, if we have this patient with ventral or umbilical hernia going to the operating room for a bariatric procedure, it's not easy to take the decision to repair the hernia at the same time. Also, it's hard to make the decision to do a Roux-en-Y gastric bypass, one anastomosis gastric bypass, or a SADS. And even it's difficult to make the decision to take this case. But we believe that we need to offer the best treatment for him. A very important point in this kind of patient is the preoperative workup with psychological and nutritional support. In our case, a patient with BMI above 50 had at least 6 weeks of diet. The group checked those patients weekly. Most of those operations can perform without difficulty. I believe the preoperative diet has a very important role for it. As you can see in those videos, the man of the picture will have the surgery without initial difficulties. Obviously, we need to have the appropriate instrument and device, and also a human team with experience doing this type of procedure. Recently, we start to perform component separation technique for patients with ventral hernia and morbid obesity. We are collecting data to be published in the future. I agree with some of you guys that iPhone is not the ideal mesh placement, but once again, the evidence show us for patients with BMI above 40 is a good option. Obviously, simultaneous operation of ventral hernia repair and bariatric surgery is not for all the patients with obesity and ventral hernia, like those cases in the slide. But for a small hernia defect should be seriously considered as the best option because there is a high rate of bowel obstruction in the postoperative period if the hernia is reduced during the bariatric procedure without defect closed. It can lead to a disaster complication like anastomotic leak. Then leave the small hernia defect without an appropriate repair during bariatric surgery should be at least questionable. Once again, thank you for your attention.
Thank you very much, Quique, for your great presentation. One question for the audience, and then we continue with Andrés. They asked what type of hernia repair they perform in the study that you presented, and which technique would you recommend?
Okay, as I told you before, I recommend hernia with defect less than 5 centimeter diameters. And for patients with morbid obesity, I guess Hypon technique is the best option for those patients.
Perfect. Edgardo, any question or comment for Quique? Then we go with Andrés, and then we continue.
Quique, do you use some injection of some product for muscle relaxation or something like that?
With those kind of patients with hernia defect less than 5 centimeters, no, we don't use that. For repair hernia with bigger defects, sometimes we use them.
Okay, thank you.
Excellent. Boza, any question? Where are you, Boza? In Las Vegas.
Boza is in Las Vegas. It doesn't.
Driving.
I'm here with Rami.
My God. Hello, Rami.
Frank, Medtronic.
Hello, guys.
So, one question. Have you done component separation when the defect is too big?
No.
Or you prefer that not to do it on the same time of the bariatric surgery?
I guess for big hernia, it's not an option to do the operating both procedure at the same time. I am talking about a hernia defect less than 5 centimeters. This is the kind of hernia that I do first hypon, and now we are doing component separation for those kind of hernias.
Excellent. So, Andrés, shall we continue with your presentation, and then we will have all the questions and opinions from our panelists.
Good evening, everyone. I'm very grateful for the opportunity to present today. Dr. Arias made my presentation a lot easier. Actually, he showed a couple of pictures of patients of mine. But what I want to emphasize is that not all patients are equal. There are some groups of patients in which the obesity is the main problem, but there are also a group of patients in which the hernia is actually the most important problem. I have nothing to disclose. You are all familiar with the concept that obesity is a well-known risk factor for the development of primary and incisional ventral hernias, and also represents a huge factor for complications or recurrences after the repair of this kind of defects. We see these kind of patients very frequently in our office, and obviously we are all involved in the bariatric field. So the combination of this kind of problems is not unusual. And this is what we used to do several years ago. This is a patient with a BMI of 38. She had an M3 defect, and we performed a sleeve gastrectomy and an IPOM plus repair. But we don't do this anymore in most of our cases. What do the literature shows today? There are several publications that conclude that with higher BMI, also the likelihood of recurrence is higher also. So for obese patients, most of the publications recommend a staged approach, usually beginning with bariatric surgery and deferring the hernia repair until the patient has lost significant weight. But there are some conditions in which this is not applicable. As you all know, there are some patients that cannot undergo a bariatric procedure, or they have complicated hernias, as I will show in a minute. This is a paper actually that addresses the guidelines on obesity and abdominal wall hernia management from the Endohernia Society, and they recommend that laparoscopy should be the preferred approach, because as I will show you in a minute, it's not the only option. And in obese patient, defect size is significantly larger. In obese patients with defects larger than 8 to 10 centimeters, a more extensive overlap, more mesh fixation devices has to be used, and the defect is advised to be closed. This is the Carolina's equation for risk calculation in patients that will undergo a ventral and hernia repair. And as you can see, BMI is a very important factor. Here I made the example of a patient with a BMI of 30.4, and the risk of complications in this case is around 10%. But if the BMI increases importantly to 45.7, the risk of complications increase to 23%. And if this patient is also diabetic, has also diabetes, the risk of complications raises to over 30. And as you all know, if you vulnerate the bowel, as it happens in most of the bariatric procedures, the risk of complications increases a lot, and the numbers are around 60%. So what are the options we have? We can perform abdominal wall reconstruction without weight loss surgery. We can perform the weight loss surgery and in a stage approach perform later the abdominal wall reconstruction, or we can decide to perform a concurrent weight loss surgery and hernia repair. Addressing each option separately, if we perform abdominal wall reconstruction without weight loss surgery, perhaps the risk is high recurrence rates. If we decide to undergo with weight loss surgery and in a stage approach to perform the abdominal wall reconstruction later, the risk is that the patient could have a bowel obstruction in the period between the two operations. And if we decide to perform concurrent surgery, the risk of mesh problems or mesh infections or surgical site infection are higher, and we have also a higher recurrence rate. So we have to balance these risks. On one side, we have the recurrence rate, and on the other side, we have the bowel obstruction rate. Also, with the combined procedures, the mesh infection rates are a little higher, and the length of stay is also higher. So this is a meta-analysis. It's getting a little old because it was published in 2016, and it addressed the best papers on the topic, trying to find out if ventral hernia repair should be performed at the same time of bariatric surgery. And in those papers, and the first paper of Ed, published in 2004, made the suture repair in 69 patients with a recurrence rate of 22%. They did mesh repairs in 12 patients. They had no recurrences in a follow-up period of 13 months, and they got small bowel obstructions in the deferred group in 35.7% of the patients. So in this is the paper of Ed, and another paper from Newcomb including a meta-analysis. It was published in 2008. They performed Roux-en-Y gastric bypasses or one anastomosis gastric bypasses. They reported 27 patients. They did 4 suture repair with 100% recurrence rate. They did 3 mesh repairs with a recurrence rate of 100% and an infection rate of 33%. When they decided to do a delayed repair, a 5% of small bowel obstruction occurred. This is another paper published in 2008 by, this is the paper by Newcomb. And this is the paper by data included in the meta-analysis we're addressing now, also published in 2008. They did Roux-en-Y gastric bypasses in their patients with a follow-up period of 14 months. They did 8 suture repairs with a recurrence rate of 25% and 10 mesh repairs without any recurrences. They reported no mesh infections, and they had no small bowel obstructions in the delayed repair group. And here you have the data. The meta-analysis reported also another paper from the same author, Ed, published in 2013. They did several groups. In group 1, they did laparoscopic mesh repair and Roux-en-Y gastric bypasses with no recurrences. In group 2, they did Roux-en-Y gastric bypasses, and they performed ventral hernia repairs using biological meshes. They had a recurrence rate of 10%. And in group 3, they prepared the patients with diet. They performed Roux-en-Y gastric bypasses plus ventral hernia repairs, and they have no recurrences. And in group 4, they did weight loss surgery and delay a mesh repair with a recurrence rate of 33% and a small bowel obstruction risk of 33%. This is a patient of us. This patient, he was 48 kilograms per square meter in BMI, and we decided to perform a Roux-en-Y gastric bypass. And after 8 months, we did an ETEP repair, placing a retromuscular synthetic mesh, and you can see here some of the stages of the approach. There are some patients that cannot wait until they actually lose weight or undergo a bariatric procedure. This is a patient with a previous mesh erosion. This is a patient, unfortunately, we didn't operate on him. He was referred to another center, but obviously the ventral hernia and the skin problems are the main concerns in this case of patient. This picture is of a patient of mine. This is our office. And as you can see, in this patient whose BMI is over 50, most of the stomach is inside the hernia sac, as you can see here. So it's not an easy case to perform a bariatric procedure. So we decided to place a gastric balloon and to start liraglutide, a GLP-1 analog, and we are in the pre-op period for operating on her. This is another patient with BMI of 38. We obtained a significant weight loss to a BMI of 31 using liraglutide. We started with botulinum toxin. We performed previous pneumoperitoneum, as you can see here, and we performed an open repair. He had several previous placed measures in all of the planes of his abdomen. We did an open repair with anterior component separation, as you can see here, and the results were very, very good, as you can see here. And in these huge defects, laparoscopic surgery is not that easy to perform, so we prefer open approaches in these patients. This kind of defects has there's no question about this. We probably will repair this kind of defect during the index operation. We recommend to repair them by suturing the defect and placing a synthetic mesh, ideally extraperitoneally, and that's the way we usually address that. This is a paper published in 2006 about the concurrent gastric bypass and repair of anterior abdominal wall hernias. They had no infections in their series, and there are some patients that in whom the ideal sequence of events is weight loss surgery first, and a very complex abdominal wall reconstruction after. They can undergo abdominoplasty, resecting all the skin, the redundant skin, and perform the repair in the second stage, as you can see here in the image, with this kind of results. So current evidence does not provide a consensus about the optimal time to repair a ventral hernia in a bariatric patient. Also, there is not an optimal approach to obese patients with ventral hernias in terms of type of repair, the use of type of mesh, or if the hernia repair has to be done before, during, or after weight loss surgery. The evidence in the literature in favor of any of the option is very weak. The number of papers is low, and in general, the series are short to draw conclusions or definitive conclusions. If on if the hernia repair and the bariatric surgery should be performed simultaneously, or a pair, also a part of an staged approach, what we strongly believe that is the ideal sequence of events. Therefore, every case has to be individualized, taking into account the size of the defect, the characteristic of the patients, the location and the contents of the hernia defect, and the type of the planned bariatric procedure. If you find a defect with the omentum stock in the defect, obliterating the defect, we will not take the omentum down. We will do the sleeve or the gastric bypass, because the omentum stock in the defect will hopefully protect the patient from getting a small bowel obstruction, and the problem will be addressed in the second stage of the repair. Thank you very much.
Excellent, Andrés. Thank you very much for your talk. Edgardo, Camilo, I don't know if Camilo is connected. Let's go for the comments and questions from the panelists. Shall we start with Priscila?
Yes.
Well, great. Thank you, Mariano. Well, excellent presentations. I'm glad because we don't have this type of patients in Bahia Blanca, in my city. So it's very difficult for us to see this type of ventral hernias. And probably my experience is it's size for this because we don't have it. I am very agree with Andrés in his conclusions that it's difficult to have a consensus in this type of patients because every patient has a different pathway of being treated. I think that probably what we have to do is to treat these patients multidisciplinary. Having a weight loss possibility without a surgical approach, I think it's mandatory in these patients with a huge BMI, probably with balloons, with medicines, or doing something different of having a bariatric surgery. And of course, trying to do or to be the less warm to the patient in our condition. If we have the possibility to have a complication in the technique that we are going to have, or we think that probably this patient is going to have an infection or a bowel obstruction, we'll try to be big in our mind and be the less warm to the patient. I think it's great what you presented here, and probably we have to study a little bit more these patients and be consensus in that if we don't have the experience to treat these patients, please derivate the patient to someone who really do it as we do. We have a surgeon that is a specialist in wall treatments in this type of surgeries, and because we don't do it in our quotidian practice. So congratulations to both of you.
Edgardo?
I agree with Andrés. I think we need to take a decision patient to patient, and I agree we need to take care with a little hernia, less than 3 centimeters, because the bowel obstruction could be a good problem in the postoperative time of bariatric surgery. But we need to take the decision patient to patient is, I think, the best advice for the auditory.
Great. Marcelo, your questions for Enrique and Andrés, and your comments, please.
So good night. I think both presentations are very good, but we are talking about the very different patients. So that depends essentially the size of the hernia and what is the most important thing here. So is it the abdominal wall defect more important than obesity? In several of those patients, it will be. So the bariatric surgery is going to be used like a tool to manage the abdominal wall defect. So this is something completely different from a very small hole in the abdominal wall. So I completely agree with the last words of Andreas. When you have a small hernia and you have a peplum inside of it, don't touch it. It's occluded. It's not going to have a major issue. The patient will have this kind of a plug that will be inside of the hernia. So if does not bore you during the surgery, you have to leave it there. That's the same rationale behind closing it with the sutures. So the sutures, and that point I don't agree with the majority of the papers, because the sutures, they're not there to correct the hernia. This is only a kind of a bridge. This patient, you're going to go back and then you're going to put the mesh. So it's just to assure you that you're not going to have a major complication of bowel obstruction. So suture is not to correct the hernia. That's why I think the end point here is not the recurrence. Those patients that are complicated, you have to go back there and then you put the mesh. And the mesh should be put, of course, in the right position. So this is another thing. There is a major issue about all those papers. should we put a iPhone, a mesh, a dual mesh, in a place where we had the contamination of the bowel? So this is completely against what we used to do. Every time that we had a gross contamination, we stopped the hernia, the hernia defect correction. So should we discuss this again? So I don't think that we have to put meshes when you have a contamination of the bowel. So and there was enough of evidence in literature to make us believe that this was not the correct thing to do. So in general, I think we have to individualize each one of the patients, but the majority of hernias will be small ones. Keep it closed by the epiplum, if it's the case, or close it with the sutures. And the major hernias, we have to think about the bariatric surgery as a tool to correct the major problem of the patient, that will be the abdominal wall defect. These are my general comments, and I want to hear from Andreas, and I want to hear from Enrique. What are your comments on that?
I do agree completely. We have to individualize the patients and try to address what is actually the main problem of the patient. It's not the same if you have a big patient as I showed, with a defect, with a hernia sac that reach her knees, and you have a huge defect with most of the abdominal content inside the hernia sac. It's a totally different animal. So you have to prepare that patient, trying to get some weight loss, but you will have to fight that animal, preparing that patient in the better way, using all the tools we have today, using a botulinum toxin, using pneumoperitoneum, trying to use some endoscopic measures, trying to increase the weight loss. We have extraordinary endoscopic procedures today that could be of use in this kind of patients. But the main problem in the lady I showed, whose pictures I showed, is the abdominal wall problem. And on the other hand, we are all familiar with some bariatric patients with small defects or things like that. We can deal with those patients and perhaps perform the weight loss surgery, trying to be very aware of the risk of small bowel obstruction in the period between operations. But the best approach is the stage approach, as you see in the guidelines I've mentioned.
Kike, any?
Hello. Yes, I am agree with you guys that if we have big hernia defects, it's better option to do the surgery in 2 stages. But my first concerns is about the small hernia defects, and if you can perform the bariatric surgery without reduce the omentum, it's okay. But sometimes you can do that. You can do a safe surgery, safe bariatric surgery without reducing the omentum. This is my question. What do you do if you cannot do the bariatric surgery safely without reducing the omentum? I guess for those patients, it's better idea to perform the surgery simultaneously, because if you wait, you can have a small bowel obstruction at future.
Thank you, Camilo.
Very nice presentations. I would say that I totally agree with all of you, but sometimes do you have sometimes the option to not use mesh and try to close just to prevent any obstruction and then do the final repair? What is your impression about that? Or if you're going to do something, always using mesh?
I guess the trouble with only put suture is the recurrence, because the higher rate of recurrence after put some stitches will be worse if you put stitches and then you convert the hernia defect, for example, 5 centimeter defect, you convert with the suture in a 2 centimeter defect. And you know the small defect will be worse for patient talking about a small bowel obstruction.
Do you remember the argument of some surgeons about mesenteric defects closure? In those days, we heard a lot that you were making a big defect, you were converting a big defect into a small defect. As well, time has demonstrated that mesenteric defects and Peterson's has to be closed. But in terms of the abdominal wall defects, if you have a huge defect, the risk of a small bowel obstruction is a little lower than when you have smaller defects. If the defect is near to bony structures of the rib cage or the pubic bone or something, the risks are actually higher of getting a small bowel obstruction. But I think that just suturing the defect is not an option. You will create bridges of suture. Actually, you will have a recurrence. I think it will help very little, if any, in preventing a small bowel obstruction.
And one last question for patients: what is the meaning, the role of making patients lose weight to do it in concomitant? Because that's I think it's a good idea. I have done endoscopic gastroplasty as a previous surgery before, so we can then do a final surgery with the hernia repair.
Yeah, for sure. The recurrence rate is lower if and it has a linear relation with BMI. So if you can obtain some weight loss, the results will be better, and the surgery for sure will be easier.
Before going with Luis and Ernesto, we have a question from Joana Murillo. Joana, your hand is raised if you want to do the question. If not, we continue with Ernesto. Ernesto, go ahead.
Okay, thank you. And thanks
Joana,
for having me here.
Sorry, Joana. Joana is in the screen.
Okay.
Joana,
Okay.
we hear you. No, Joana. Go ahead, Ernesto, please.
Well, thank you again. Well, I think we have basically three different points of view in this topic. Three professional different points of view, because we have the surgeon who is specialized in complex hernia, we have the bariatric surgeon, and we have the bariatric surgeon who has expertise in complex hernia, right? And in this case, in this topic, we need to focus very well in the management of the hernia. It has been somehow arbitrary to get those patients with a specific diameter, for example, 5 centimeters, when we know that an abdominal, a complex hernia is that big, with a defect bigger of 10 centimeters, right, in diameter. So these cases definitely will have to go to a more advanced procedure like component separation, right? But when we look at the statistics, we can see that the higher complications are seen on those patients with a BMI over 40. In a recent review of the MBSA QUIP database that was published in obesity surgery, by the way, in 2020, we saw that 15,000 cases were, underwent concomitant procedures with bariatric surgery. And among those cases, 3,400 cases underwent gastric bypass with ventral hernia repair, and 6,700 cases underwent sleeve gastrectomy with hernia repair. And among these patients, we got that the higher BMI was a higher risk of death and complications. So this contradicts most of those case series that have been discussed in these presentations, that the hernia repair is safe. I mean, because the publications have been so limited, and now we have the review of the MBSA-QUIP database that is showing that doing concomitant procedures in bariatric surgery is very risky. On the other hand, it has been mentioned that vertical endoscopic gastroplasty is a very good new procedure that offers at least 25% of total body weight loss. And this is a very good opportunity for those patients who have unapproachable abdomen, right? We have seen many cases of patients who had abdominal catastrophes with giant hernias, with loss of domain. And this can also be extrapolated to those patients with defects that are not suitable to undergo bariatric surgery for any other reasons, right? And on the other hand, the use of GLP-1 analogs, as Dr. Daes mentioned before, are also a very good alternative. So the point here is that I think we should see the hernia as a hernia specialist is approaching it with a multidisciplinary approach, as it has been mentioned before, and have it on the arsenal of other procedures to offer to those patients who are not candidates for a laparoscopic procedure, and in the end, individualize each patient.
Enrique, Andrés, any comment?
No.
My final comments on this, probably I have been repeating the same. We have to individualize the patients. I think that we have very important tools today trying to improve the patient's conditions in terms of weight. Bariatric surgery is one option. Fortunately, is probably an option in most of our patients because you don't see this kind of monster hernias every day. My practice involves both fields. I am a bariatric surgeon and also an abdominal wall surgeon. So I receive patients with both kinds of problems, as I said before, and we try to address a problem that is the main issue in each patient at the time, and trying to use all the tools we have today to get the best possible result.
Okay, Mariano, I just want to ask to answer to John Carrasco, who is asking about if we find a ventral hernia, we change the decision of the kind of bariatric procedure that we will do. I think that sometimes yes and sometimes no, because I guess I am not talking about complex hernia when I talk about the hernia defect of 2 centimeters. But I think this is the most important hernia that I have to approach during the bariatric surgery. Because the big hernia is not a trouble. These guys will not have any complication related to his hernia in the postoperative period. He can wait until an expert to perform a complex wall component separation, and I don't do that. I am talking about the small hernia defect, and for those patients, I guess if I think that gastric bypass is better because he has reflux, he has diabetes, and has a umbilical hernia, for example, of 2 centimeters, I don't change my bariatric surgery procedure. I still need a gastric bypass, and I do the gastric bypass at the same time of hernia defect close with a composite mesh using IPON technique. Or if I could do, I do a component separation by laparoscopy and put the mesh between the wall components.
Great, Enrique. Luis, your comments and questions for Enrique and Andrés?
Yes, thank you. Congratulations for both great presentations. I think that management of complex hernia in obese patients should include first weight loss. But what about patients who deny bariatric surgery because of preference or because of money? I don't know, maybe the cost of the surgery. Should we deny the treatment of the hernia? You know, maybe here we are going to use more and more all the medications that we are seeing now that are available. And also, once in a while, we see a group of patients, patient with parastoma hernias. I don't know if somebody here has treated these patients before. What do you do first? You treat the stoma in case the patient wants to close the stoma. You treat the hernia, or you treat the obesity. These patients, I think, that very complex and challenging, defining the best approach for them. And also for Dr. Arias, I like your presentation, I like your videos. And what about how many minutes does it take to you to perform the component separation in case you perform further the bariatric surgery? We recently treated a patient with rhabdomyolysis. So this also is very complex in these patients because the surgeries are longer than normal surgeries.
Okay. I think it's around 40 to 50 minutes plus to perform the component separation of the IPON technique in a patient to perform a sleeve gastrectomy or gastric bypass. I think that you have to get around 40 to 50 minutes more. I think that for those patients with component separation, sometimes I have to be completely honest with you. Sometimes I plan component separation for some patients, but it's really difficult sometimes, and I could not do in all my case the component separation right now. I start with component separation around 2 years ago, and only for small hernia defects. But sometimes I could not do that, and I changed my technique for IPON and use a composite mesh in those cases.
When you say a component separation, you're meaning TAR, transversus abdominis release,
yes,
or because there are several forms of component separations. You can perform also anterior component separation endoscopically. Dr. Diaz described that many years ago, and it's an easier way to address the same problem. We do posterior component separations routinely but in big defects, not in small defects. Okay, because trying to address or trying to obtain the possibility of closing the defect, because abdominal wall is not a passive barrier; it's a functional structure. So the treatment of a defect in the abdominal wall is not just patching a hole. You have to reconstruct the anatomy and the function of the abdominal wall. So closing the defect is advisable. It's a cornerstone of the actual repair that we want to do in these patients. Okay.
Excellent. For Andrés and Enrique, Carlos asked if you have a very huge hernia in a super obese patient, is any choice to do first a laparoscopic sleeve gastrectomy and then in a second time the bypass or SADIS and the component separation technique?
That's the way to go.
I agree.
So we would like to have the final comments of Priscila, Ernesto, Marcelo, and Luis. Priscila.
Well, I think it's
very, very quick comments because we are on time.
I think we mostly agree in the behavior in these patients. Every patient is different, so we have to be aware of being able to individualize the treatment for the patient. And as I said before, the less we damage, the better we treat the patients.
Marcelo?
We have a very dedicated group of researchers here that were working with biologic meshes, bovine pericardium. And I think this could be a a very interesting new option for those patients. We are working in antibiotic impregnated meshes that are stronger than usual and much cheaper than the meshes that we have. And we are doing tests in animals. I think that would be one more answer to those kinds of patients, because the impregnated meshes, they simply don't get contaminated. So I think in that specific situation, that would be a big help.
Ernesto?
Okay, just to remark the fact that we need to review the MBSA QIP more. We need to put more attention to the MBSA QIP, because it is reporting something that we have not seen before, and that might create a new approach for these patients.
Perfect. Luis?
Great topic, great presentations. I think the more complex the patient, the more stage approach should be better for the outcomes of each one of the patients.
Great. Allow me one last question, and then Edgardo, you close the session. From Edward, how about TAP for ventral hernia in obese patients? For Quique and Andrés.
I would do TAP as a stage approach in the second stage in some small defects. But I think that doing TAP in the index operation, it's complex, it's difficult. You add all the preperitoneal dissection in the thin peritoneum. I'm not very prone to do that.
Yes, I have some experience doing TAP with umbilical hernia, but with a small defect and patient without obesity. I think for patient with morbid obesity is not an option at this time, at the same time of bariatric surgery.
Perfect. Edgardo, the close is yours.
Thank you, Mariano. Thank you all of the speaker, Andrés and Quique. Congratulations for your talks. Thank you, Priscila, Marcelo, Ernesto, and Luis for the comments. Thank you, Sergio Aparicio, and our chief, Dr. Lucho Poggi, for of IFSO-LAC, and thank you, and Global IFSO too. And please keep in touch with IFSO-LAC for the next webinar, please. We will talk with you in the next time for next webinar. See you, all of us.
Thank you very much. Bye, guys.
Thank you. Bye.
Bye. Thank you.
Bye-bye.